Greetings of the day, everyone, wherever you are. Welcome to Radiology International Lecture Series. Doc Plexus is our digital outreach partner. And for those of you who would like to view the session again, it will be available on the YouTube channel of Gapio. And may I request the audience, if you have any questions, please place it in the chat box. And for those of you who are joining for the first time, I'm Dr. Vinita Sharan, and I'm the CME advisor for radiology for Gapio. Well, many of us may take CT scan of the sinuses not very seriously or may underestimate its power. Today, Dr. Suresh Mukherji is going to enlighten us on all the things that may possibly go wrong. So to start this session, I would like to introduce our moderator, Dr. Nidhi Goyal. Dr. Nidhi Goyal is a senior consultant of radiology at Indraprasth Apollo Hospital, Delhi. She is a thesis guide as well as an assessor for National Board of Examination. Dr. Nidhi is editor of Journal of Orthopedics and reviewer of Indian Journal of Radiology. She has expertise in cardiovascular imaging with special cardiac MRI, MSK radiology, and neuroradiology. She has approximately 10 chapters in various books and 20 publications in various national and international journals, and more than 30 presentations. And she has also been awarded with IRIA President's Appreciation Award. So, Dr. Nidhi, I hand over to you. You have to unmute yourself.
Thank you, Dr. Vinita. I should have shared a few things with you. I'm sorry for that. And good evening, Dr. Suresh, and welcome to the evening session. Good evening, Dr. Saurabh.
Good evening, ma'am.
I will introduce Dr. Saurabh, who will be the chairperson today. He's a consultant in the Department of ENT at Apollo Hospital, Indore. He has over 18 years of clinical experience in the field of ENT, and he has performed more than 5,000 major and the minor ENT surgeries. His expertises includes cochlear implant surgeries, endoscopic sinus surgeries, skull-based procedures, CSF leak repairs, pituitary craniopharyngiomas, skull-based nasal surgeries, thyroid surgeries, and advanced ear surgeries. Apart from the clinical practice, he is actively involved in the academics and the medical education, has presented research at national and international conferences, and currently serves as a Vice President MP State of AOI. Welcome, Dr. Saurabh. And if you can now kindly introduce Dr. Suresh for the session. Thank you.
Good evening, everyone. Thank you, Dr. Nidhi Goyal, ma'am. It was a wonderful evening because I'm getting a chance to just join this wonderful session. Uh, as everyone says, there is no need of introduction to Dr. Suresh Mukherji, sir. But he's a dynamic person. He's having a so good introductory part. I'll start with he's a director of head and neck radiology, pro-scan imaging, professor of radiology at University of Louisville, and professor of radiation oncology at Robert Wood Johnson's Medical School, Rutgers University. His primary scientific interests have focused on investigating emerging metabolic and physiologic imaging techniques to evaluate head and neck cancer and to differentiate recurrent tumors from post-therapeutic changes. These technologies include imaging with fluorodeoxyglucose analogs, image with prototype single photon emission computed tomography gamma cameras, standard PET and CT PET. Other metabolic and physiologic imaging techniques he has investigated include thallium 201, magnetic resonance spectroscopy, CT perfusion, and CT spectral imaging. He has also written or edited 15 textbooks and is the consulting editor for both neuroimaging clinics and magnetic resonance clinics of North America and associate editor for the Journal of Computer Assisted Tomography. He, had, he has been an invited speaker on nearly 400 or more occasions. So it's a wonderful part. We are getting a chance to listen him. First, I'm getting it for the first time. And regarding this topic of CT scan of paranasal sinus, which I want to say, being an ENT surgeon, we need every time a good clinical studies relevant to this and clinical information regarding this. Sometimes we fall into the problems regarding the CT scan. So I would like to invite here our Dr. Suresh Mukherji, sir, for the wonderful session. Sir, please.
Great. Thank you very much. Can everybody hear me okay? Yes?
Yes.
Great. And okay, great. And then can everyone see my first slide?
Yes, it's clearly visible. Please go ahead.
Okay, great. Okay, well, again, thank you very much for having me. It's always a pleasure being here. Just a little introduction about myself. My parents were born in India in the last century. I grew up in the last century. We moved to the United States, but you can physically you can take someone away from India, but you really can't take someone's soul from India. So despite the fact that it's been probably 55, 60 years since I've been there, I always appreciate the opportunity. I'm not the smartest person in the world. I'm never going to create an iPhone. But on the other hand, if I can maybe make a difference in one patient or one person at a time every day, that's good enough for me. So again, thank you very much for having me. When you look at this slide, I think it's probably true that if you're a radiologist, this is radiology that nobody really wants. And that was something I learned a long time ago. So I kind of joke that head and neck radiology it's kind of job security because, a lot of people just don't like to do it. But the funny thing about head and neck radiology is that when it comes to sinus CTs, it seems like everybody loves to do sinus CTs. So, sometimes, I think it should be done by head, neck, and neuro person, but everyone wants to grab it because everyone thinks it's kind of pretty easy to do. And I think that's probably true. And really the goal of this is not to dissuade people from doing it. But on the other hand, you're kind of thrown into reading these studies. And I have, lots of talks. I think I have about 5 or 6 talks just on sinus CTs. And I'm not going to go into specifics of infectious or inflammation or even preoperative evaluation or tumors or really approaches to anterior skull-based lesions. But I do want to briefly go over just the anatomy, which will sort of introduce us into this talk. So I know that everyone knows there's a frontal, there's a maxillary, there's an ethmoid, and there's a sphenoid sinus. So that sort of goes without saying. And like I said, I have lots of drill down talks on this detailed anatomy. But the point that I want to make in this talk is that despite the fact that this is quote unquote head and neck radiology, it seems like everyone's very happy, this smiley face happy to read these studies. And everyone wants to grab that sinus CT, I guess, as opposed to reading a post-op neck or something like that. So it's sort of, everyone loves it. So as a result, what I wanted to do in this particular talk is really talk about it's just a sinus CT. And really what can possibly go wrong? Because if you go back and look at this, you're sort of looking at the beautiful Serengeti here. And if you're not careful, it's possible you could get eaten by this lion. So the point of this talk is really to prevent how you can get eaten by a lion when you're enjoying interpreting a very lovely sinus CT. So the first thing that I want to do is talk a little bit about the technique. So when we do talk about technique, and I get studies from all over because I spend 2 days a week more community face, and then I spend 2 days a week in a tertiary/quaternary academic care facility. So I see a wide range of different types of studies and techniques, even when it comes to sinus CTs. So obviously now in 2026, everyone's doing this with helical imaging. Unfortunately, I grew up in the last century. I was born in the last century, and I still remember the days before there was actually helical, or we used to call it spiral CT, but obviously everyone's doing this now. Everyone's probably, and they should be doing sub-millimeter acquisitions. In general, we are acquiring these in the axial plane, and we're performing coronal and sagittal reconstruction. So number one, all of your sinuses should be done in axial, coronal, and sagittal reconstruction. The second pitfall that I tend to see is that they should be reconstructed in bone algorithms. Now, bone algorithms is specifically the kernel that you use. So when you start to look at some of the detail that I'm going to show that's going to sort of, if you will, keep you out of trouble, you really need to look at that bone algorithms. And lastly, we always look at the soft tissue algorithms. Now, some people will say, well, I don't want to look at the soft tissues. It's not necessarily. But on the other hand, from my standpoint, I've always felt that if someone's going to come in and we're going to be paying for our healthcare costs, I think they deserve a comprehensive examination. But what you don't want to do is take the soft tissue algorithm acquisition, window it, and then look at the bones basically in a lack of detailed view. So the radiologists on the call will know what I'm talking about. So for the surgeons, don't worry about it. For the radiologists, please reconstruct in bone algorithms, not bone windows. And that's going to allow you to look at some of the details that we're going to see. So the next thing that I want to talk about is interpretation. Like I see a large variety of different types of sinuses coming in. And so this was actually an actual interpretation that I saw. So this was mucosal thickening in right maxillary sinuses. Other sinuses are clear, bony structures intact, ostia are open. Now I put this on a PowerPoint presentation with a relatively large font. If I kind of open it up and use a smaller font, this is like a one-line dictation. Now you can look at this and you can say, well, it sort of gets to the gist of what you want to do. And I kind of call these people cheetahs. These are really fast. They'll say everything is a little bit of mucosal thickening, everything clear, done, go on to the next case. And sort of what they're doing is saying to the surgeons, this is what I think globally, you go figure it out. Now, this is another interpretation. So this was an interpretation coming from a tertiary / quaternary academic facility. And this is what their interpretation was. So this was the right side. They talk about the maxillary sinus, the ostium, the frontal sinus outflow tract, the anterior ethmoid cells, the posterior ethmoid cells. Then they do everything on the left side. So that's page 1. And then they go to the sphenoid sinuses, and they talk about all these important structures, the chambers, the ostias, the recess, the walls, the intersinus septum. So that's page 2. And then they go to page 3. And now they look at the lamina propria, the cribriform plate, the lateral mela, the ethmoid roofs, so on and so forth. They even talk about the IACs, the middle ear cavities, temporomandibular joints, all important information. Now, this is what I would call the turtles. This is a great dictation, but on the other hand, it's pretty detailed, which I think is important as well too. And I'm not really advocating one versus the other. In fact, I remember I gave a talk at our annual meeting of our Head and Neck Radiology Society, and I remember I showed this slide, and someone that is a long-term faculty at a major institution, in fact, voted one of the best in the world consistently, came to me and said, well, to be honest with you, don't tell anyone, but I'm more of a cheetah because us rhinologists like the short reports. Now, so what I'm saying is there's nothing wrong or nothing right, if you will, but I think a lot of it has to do with what the expectations are from your referring physicians. Now, this is what I do. So what I do is I have a one-page dictation. I talk about, it's sort of a hybrid, if you will. It's the frontal sinus, the ethmoid sinus, the sphenoid sinuses. Then I break it up into the right and left maxillary sinus. Then, as you'll see, I always comment on the nasal cavity, the anterior skull base, the temporal bone, the orbits, and the brain. So you can see I'm kind of somewhere between a cheetah and a turtle. So it's, maybe it's a lion like I showed before. I don't know. But on the other hand, I do like to cover the majority of the areas. And within that, then I'll try to drill down into some of that anatomy. So if anybody wants this template or anybody wants to take a little picture of it, this is what I use in my macro or template when I'm doing my reports. The second point that I want to make is the whole concept of sinusitis. So sinusitis is a clinical diagnosis, and I really can't emphasize that enough. And why am I so sure about this? Well, back when I was a resident, again, years ago, when I trained in the Harvard system, I was a first-year resident, and my first day was on neuroradiology, and I fell in love with neuroradiology. And my second day, I fell in love with head and neck radiology. So the next year I came back, and I was on the neuro rotation, and I'm reading out the neuro ICU board. And that time we called them boards. I trained in the days of plain films. You can Google it if you don't know what it is, but in the days of plain films. So I was reading the board out. And I was on the neuro ICU. We had all these patients that had these huge intracranial hemorrhages. Some of them had herniations, but me, because I loved head and neck radiology, I would say impression number one, large intracranial hemorrhage. Number two, I noticed that there was some mucosal thickening involving the ethmoid sinuses in these intubated comatose patients. So I would say ethmoid sinusitis. So about 2 weeks into the rotation, my division director comes up to me and says, "Hey, Suresh, how's it going?" And the last thing you want to hear is your boss coming up to you and asking you, "How's it going?" Because you've done something. And I said, "Well, Dr. So-and-so, everything's great. Is there anything going on?" He said, "Yeah, you may want to stop using the term sinusitis in these patients that have opacification of their ethmoid sinuses or their maxillary sinus." And I said, "Why?" I was told this was sinusitis. And he said, "Well, the ENT department and the surgeons are getting a little upset." And I said, "Why?" He said, "Because on all of those comatose patients that are herniating, they're being consulted because you, the radiologists, are actually using the term sinusitis." So the point is that I learned very quickly, again, 30, 40 years ago, that sinusitis is a clinical diagnosis. Now, what we can do is suggest a diagnosis of sinusitis if we see an air fluid level. So on something like this, I'll say, well, there is a partial opacification, and I use the term mucosal thickening. I try not to separate between a cyst and a polyp, but I was taught mucosal thickening as the term. So in this case, I would say mucosal thickening, and there's an air fluid level which could be consistent with the clinical diagnosis of acute sinusitis. And I've used that over the last 35 years, and in general, it's worked pretty well for me. So what could go wrong on something like this? So the one thing I want to emphasize is that anytime that you have an air fluid level in the frontal sinus, realize that there is a bony separation between the frontal sinus and the intracranial contents. Now, what is present is that you have these draining emissary veins that extend from the sinus. They traverse the posterior wall of the frontal sinus, and they can drain into the intracranial cavity. And what can happen is that this opacification can erode the posterior wall of the frontal sinus. And if it does, all of a sudden the sinus is now direct communication with the intracranial cavity. So this was a patient that had diffuse soft tissue thickening involving the frontal sinus. And in this case, we can see this abnormal enhancement, and this is diffuse meningitis. And in fact, if you look anteriorly, we can see diffuse enhancement of the soft tissues with soft tissue thickening. Here's a little air right here, and this is the classic Pott's puffy tumor. So you can have this Pott's puffy tumor involving the soft tissues, or if that infection extends posteriorly, it can traverse these emissary veins, and this patient can result in a meningitis. And this is another example of a patient that has diffuse meningitis and has developed an intracranial abscess. Now, this is an example of a patient, and again, we're talking about infectious processes, but realize not everything that erodes the frontal sinus is going to be an infection. This was an example of a large squamous cell carcinoma involving the forehead, and this was a forehead skin cancer. Always remember, when you are evaluating patients that have forehead skin cancers, remember, you can always see these large tumors that just stare you in the face. Unfortunately, I'm lucky in the sense that every Wednesday I actually see patients in a tumor clinic. It's somewhat unusual for a radiologist to be in a tumor clinic, but I always have to caution our referring physicians is before you go in and try to do some type of wide local excision, remember, because of those specific lymphatics and those veins that traverse the anterior skull base, you can also have this dural enhancement and tumoral extension and still have an intact posterior wall. So for those of you that are in a high volume oncology center, just remember, anytime that you have these large forehead cancers, always to try to get an MR to look for that dural involvement. Well, here's another example of quote-unquote sphenoid sinusitis. This is the classic example of mucosal thickening involving the sphenoid sinus. If you look real closely, we can see some bubbles here. I use the term frothy secretions, and we can see a little air fluid level. So what I would say on this, opacification, right sphenoid sinus, frothy secretions with an air fluid level. And I would say can be correlated with any clinical findings of acute sphenoid sinusitis. Now, this is an example of a patient right here that has a little bit of mucosal thickening. You'll say, well, it doesn't look like very much. There is an air fluid level, there's a bubbly secretions, but the majority of the sinus looks to be opacified. Well, again, one thing that I've learned through my experience, there's a saying that says good judgment comes from experience and experience comes from bad judgment. Unfortunately, I have a lot of experience because I've made some big mistakes, right? Like anybody else has. So what I have learned is when I see something like this, I always open up the windows. I widen up the windows, and lo and behold, that whole sphenoid sinus is opacified. And I didn't know what this was, but I looked it up, and this is called the fizz sign. Yes, there is a fizz sign. So this is the fizz sign. So the point is that this opacification and involvement of the sphenoid sinus is not just limited to this area here involving the lateral recess. Rather, this whole lateral recess of the right sphenoid sinus and the right sphenoid sinus is completely opacified. So this infection or this inflammatory process is much larger than you think it is. So a couple of things about the sphenoid sinus that I want to emphasize is that anytime that you're looking at the sphenoid sinus, make sure you look at the carotid arteries. Now, in this particular case, this sphenoid sinus is well aerated, but always look for that little curvature right here. This is the internal carotid artery that is adjacent to the posterior lateral wall of the sphenoid sinus. Now, what I want to always point out and mention is whether or not that carotid artery is protruding into the posterior wall of the sphenoid sinus and whether there's bony dehiscence. From a practical standpoint, no surgeon is going to operate on this. But on the other hand, this is an example of a patient that has mucosal thickening involving the right sphenoid sinus. And if you look real closely, there's that bony dehiscence. So if a surgeon is going to be performing a sphenoid osteotomy and they want to potentially remove polyps, they're going to have to put their forceps in the sphenoid sinus. And you can say, well, that'll never happen. Well, again, you know, life is all about storytelling. So again, in the last century, when I took my first faculty position, 2 weeks before I started, the ENT surgeon at the institution where I was going to was doing a endoscopic sinus surgery and was removing polyps from the sphenoid sinus. All of a sudden, they got a lot of blood that was gushing. And the surgeon said, well, oh my gosh, I've hit a hypervascular polyp. Well, they couldn't stop the blood from coming out. And at that time, we did not have in-house interventional neuroradiology. So we had to fly someone from Pittsburgh. That person came in and did an angiogram. And what they noticed is that the surgeon had inadvertently biopsied the internal carotid artery. And that was probably because the carotid artery was dehiscent and it was extending into the sphenoid sinus. So it wasn't a hypervascular polyp, but it was probably a dehiscent and protruding internal carotid artery. So from a practical standpoint, I would always try to get in the habit of looking where that internal carotid artery is. Here's another example. You think this is just opacification of the sphenoid sinus. Again, look at that posterior lateral wall, because when you look at it, this was a large, giant aneurysm of the internal carotid artery that somehow eroded into the sphenoid sinus. So don't just call this opacification, learn to look at that wall. And if you do look at that wall, remember that carotid artery. And this was another example of a patient that had opacification of the anterior sphenoid sinus. If you look real closely, there's bone dehiscence. And we told our surgeons about this, and then they ended up doing an MR. And we can see here there's direct communication of this inflammatory process in the sphenoid sinus and resulting in a meningitis. Now, I don't know if you've ever been to New York. My daughter lives in New York. In fact, lo and behold, today she's leaving New York to go to California. But if you have been there, there's something called Central Park. And right adjacent to Central Park, there are these large, large skyscrapers. This is what's referred to as Billionaires Row. It's the high rent district. And I always considered the sphenoid sinus the high rent district. Why? Because adjacent to the sphenoid sinus and the cavernous sinus, which is what we're discussing now, there's the internal carotid artery, there's cranial nerve 6. The cavernous sinus is the main venous drainage of the deep portion of the brain. And then we have cranial nerves 3, 4, V1, and V2. Well, the point is that anytime that you can have an infection involving the sphenoid sinus, it could potentially extend into the cavernous sinus. And if it extends into the cavernous sinus, you can have cavernous sinus thrombosis. So remember this cavernous sinus thrombosis. This is normal opacification on the right. And look how there's non-opacification on the left. And once the infection gets into the cavernous sinus, that inflammatory process, as I showed in the last slide, can weaken the wall of the internal carotid artery. So here's a normal carotid artery on the right. This patient ended up having invasive fungal sinusitis that extended to the cavernous sinus. Look how the lumen of the carotid artery is narrowed. And with the leap of faith, you can see this little line right here. This is the pseudo wall of the pseudoaneurysm, and this high T1 signal is methemoglobin and thrombus that is surrounding the thrombosed portion of that pseudoaneurysm. So, I don't know if there are any residents or trainees on this, but this was a paper that I wrote in 1995, and no one's ever read it, I'm sure, because why would they read it? But I was a resident at that time, and I remember I was going to do my fellowship, and my mentor at that time was Tony Mancuso, and I always wanted to write a paper. And I said, please send me something. And this is before the days of texts and emails, right? So this is all phone calls. So to get me from stopping to call him, he said, I'm going to give you 6 cases of septic cavernous sinus thrombosis, and I want you to review them. Well, it turns out it was just 6 cases, but at that time, all 6 cases of these patients that had septic cavernous sinus thrombosis, they were all on the initial study, but they were missed. So they were not seen by the interpreting radiologist. 6 of those patients, 5 of the 6 went on to die, and the 6th one had a permanent neurological complication. So the point being is, number one, that's why sphenoid sinus disease has always stayed with me, because when you do look at something like this, you never forget it. But also, for any of you residents or medical students that may be on the call, anytime that you write a little paper or even a case report, that knowledge kind of stays with you because you do become an expertise. And I can tell you now that I'm 64, I'm going to be 65 in a few months. When I look back on all the stuff that I've written over the last 30 years, what surprises me is how often that knowledge helps me at some point. It just kind of like pops up. And I have to admit, it has made me a better radiologist, because it's amazing how much that you can always remember from all these little experiences that you have. And this was an example that I had about 7 years ago. It was Friday afternoon, and I was looking at this case, and I just thought it was disease involving the ethmoid sinuses, and I was about to dictate it. And I don't know about you, but if you've ever dictated something and then you get this sense of impending doom, I don't know if you've ever had that before, but just as I was about to dictate, and I was going to say there was ethmoid sinus disease, I noticed that there was a lot of infiltration of the retrobulbar fat on the left compared to the right. And then I noticed there was a little dilatation here of this vein, and there's no flow in the vein, and that's a superior ophthalmic vein. So I called the ER, and I said, is there anything else? And of course the ER says, oh yeah. And I said, what do you mean, oh yeah? Well, the patient has a 6th nerve palsy. So now all of a sudden you've got this sinus disease involving the ethmoid sinuses, you have this fat involving the retrobulbar fat, and you have dilatation of the superior ophthalmic vein. So remember, the superior ophthalmic vein drains into the cavernous sinus. So I called them up and I said, I think the patient may have cavernous sinus thrombosis. And we did do an CTV. And what you see here is normal opacification of the internal carotid artery. And you can see there's no enhancement at all in the cavernous sinus. So this patient did have bilateral septic cavernous sinus thrombosis from this disease involving the sphenoid sinus. So this is one of those cases that I got lucky on. Lord knows I've made lots of mistakes. But the point is that I think over time, we do learn from our mistakes and we learn from our experiences. So here's another patient that has opacification in the right sphenoid sinus, right? You want to call it just mucosal thickening. But look how that wall is dehiscence. So remember, things can start in the sinus and move out. But remember, you can also have things that are starting outside of the sinus and moving in. And especially in patients that end up having intracranial hypertension, we see this pretty commonly. You can actually develop dehiscence of the lateral wall of the sphenoid sinus. And this was a large CSF leak. And when we did the myelogram, what we see here is that this contrast, this intrathecal contrast, is extending through the wall of the sphenoid sinus and is extending into the right sphenoid sinus. And this just happens to be V2 extending through foramen rotundum. So remember, when you have this wall, you can have disease inside extending out, but always remember that you can also have CSF leaks as well. Well, what about the maxillary sinus? Again, this is those principles that we talked about before. We can see mucosal thickening involved in the maxillary sinus. We can see the air fluid level, and we can see those frothy secretions. So my dictation would be all those things and correlate with any clinical findings of acute maxillary sinusitis. This is one that has a little bit of disease, maybe a very small air fluid level. But again, when we widen up the windows, lo and behold, that mucosal thickening, we see all of these reticulations. And again, this is our friend, the fizz sign. So this is not limited to what we see here, but rather that whole maxillary sinus is opacified. And instead of calling this minimal, well, guess what? This patient probably has much more disease than we initially thought. Now, when we talk about this specific disease entity, I want to make this point. If you do have someone that comes in with facial pain and clinically has quote unquote unexplained facial pain, and they are diabetic or some type of immunocompromised or even immunodepressed, because a lot of patients are now on some type of low-grade immunotherapies. Maybe they have rheumatoid, psoriatic, so on and so forth. The tendency is to call this negative. But what I want you to do is always remember to look at the soft tissue surrounding the maxillary sinus. Because if you just look at the maxillary sinus, you may call that negative. But learn to look at the fat, both anterior and posteriorly to the sinus, because what we see here is this abnormal soft tissue thickening on the right compared to the left. This is the earliest findings of invasive fungal sinusitis, because if you don't pick that up, this patient can go on to develop this. This can go on to erode the wall of the maxillary sinus. It can result in fragmentation. And remember, the superior portion of this area, which is the pterygopalatine fossa, extends all the way up to the orbit. And this is the inferior orbital fissure. And unfortunately, by the time it gets to here, it's just too late. And again, I had a case of this probably about 4 months ago. It was initially not seen on an outside CT. Unfortunately, 3 months later, the patient comes in and has just diffuse rhinocerebral mucormycosis. And when we look back on the initial study, again, we saw this early involvement right here. So please look at that at patients at risk. The other next thing I want to talk about is beware of isolated complete opacification of a sinus. This was a patient that was being followed by a surgeon for many years. And what we have is opacification of the left maxillary sinus. So when you look at this, you'll see, aha, there's opacification of the sinus, there's expansion. You know, you look at the soft tissues and you say, is it possible this is just a big polyp? Could it be a mucocele? But when we looked at the axial images, and again, this patient had been followed for a while, and then all of a sudden, we noticed that there was a little bit of erosion here involving the posterior wall of the left maxillary sinus. And in fact, when we look at the axial images, we can see that there's soft tissue extending outside. So I called up the surgeon and I say, you know, I don't think that's just mucosal thickening or a polyp. I think you may have something more aggressive. And lo and behold, he biopsied it, and it turned out to be squamous cell carcinoma. So one of the things you learn over time is that when you are reading this out, and you know, I love to hear from our friend, the rhinologist, and our surgeon later, but if I do say that there's isolated complete opacification of a sinus, at least with the surgeons that I work with, that's a trigger point where they specifically have to look in that sinus just to make sure there's nothing more ominous going on. Well, these are some pathologies that you may see when you have associated complete opacification. Here we have complete opacification involving the sinus, which is associated with a tooth. This is an odontogenic keratocyst. If you have this tooth and this cyst is associated with the corona of the tooth, this is what we refer to as a dentigerous cyst. This was a case where we have complete opacification of the sinuses. I'll never forget this case. I was looking at it, I'm like, well, here's some air, but here's the floor of the orbit, and look, there's air above the orbit. And lo and behold, this was a large subperiosteal abscess. We're used to seeing the periosteal abscesses extend from the ethmoid sinus. But in this case, the abscess extended from the maxillary sinus, and the initial trigger point was that air. And this was an example of a large ameloblastoma. So remember, you can have these odontogenic tumors give you that unilateral opacification. Well, the next thing we'll talk about is the nasal cavity. Sometimes you blow right past the nasal cavity. Remember, the nasal cavity has the various turbinates. It's the floor of the nasal cavity is the hard palate, and then you have that septum. Well, this is an example of a patient that has septal perforation. Back when I was a fellow, my attending at the time, my mentor, didn't really emphasize look at the septum because they say the surgeons can look in and see it. But I remember one case, and this may have been the case, I didn't mention the septal perforation. I got an angry call from actually a physician extender saying that dumb radiologist, they missed the septal perforation. So I saw it, I didn't mention it, but ever since then, I always mention it. So if you do see septal perforations like this on imaging, this can be due to cocaine abuse. It can be due to GPA. It could be post-surgical, and I hate to say this, it could be due to chronic nose picking as well, too. I didn't put that there, but just realize that these are all causes of septal perforation. And this was a case that I saw that walked into our clinic. We saw this patient about 3 years ago. This was a patient that had chronic cocaine abuse, and this was her CT scan. And what we see here was just complete erosion of all of the anatomic components of that nasal cavity. Well, this is an example of a patient that had a mass involved in the left nasal cavity. We see enlargement of the left inferior turbinate. This happened to be melanoma. Anytime that you see something like this on a sinus CT, make sure you mention it to your surgeons. Here's an example of a patient. You're going to call this negative, but if you look real closely, there's a little erosion here of that maxillary spine. And lo and behold, this happened to be a squamous cell carcinoma. And this was a patient on the sagittal images. You can see this nose is drooping down. This is what's referred to as a parrot beak. And again, this was a patient I saw in clinic. This patient unfortunately had a large squamous cell carcinoma that you could not see clinically and had eroded the strut of the nasal septum, which we call the columella. And when you erode that, the nose tends to droop, and this is what's referred to as a parrot beak deformity. So all things that we should look for. And this is something you should always look for as well, too. We're talking about lots of polyps, right? Well, if you look in my template, one of the things I always look for as well, too, is that when you do see something like this, and you're going to call it a polyp, and in fact, you see other disease here, always look at the anterior skull base. Because if you look at the anterior skull base, you can see that there is dehiscence here involving the cribriform plate. And this is not a polyp, but this is a large cephalocele. So one way you can make really good friends with your surgeons is that if you do see something like this and you see that cephalocele, please make sure you mention that report, because the last thing a surgeon wants to do is to go in and operate on a cephalocele and mistake that as a polyp. So we as radiologists can make a huge difference. So that's why I specifically look for these cephaloceles. And I have to tell you, this dehiscence involving the cribriform plate, I think is undercalled. I think that there are more CSF leaks than we're led to believe. So that's why over time, again, from my experience, I always specifically focus at that anterior skull base. When we're looking at the oral cavity, there's some other nuances that we should always consider. So when you're looking at this, you're just going to call this polypoid mucosal thickening. So there's unilateral opacification. On the right-hand side, we can see the primary ostium. All of us know that the standard treatment for mucosal thickening is going to be functional endoscopic sinus surgery. And I have a specific talk on this as well, too. But I'm not going to get into it here. But the point that I want to make here is that learn to look at the inferior portion of the maxillary sinus, because sometimes this disease involving the maxillary sinus is going to be due to an odontogenic inflammatory process. The reason that's important, and when I specifically say this to our surgeons, to our ENT surgeons, they would then refer the patients to a dentist. Because when they do refer to the dentist, if they perform a FES and they don't address this infection, that disease is never going to go away. So these are the patients that need to be referred over to our oral surgeons. They then end up probably removing that tooth. They end up go ahead and filling that in. And then you can then address the sinus. But again, this is what we refer to as odontogenic sinusitis. If that odontogenic sinusitis gets really bad, it can erode all the way through the bone of the sinus, and it can develop an oral antral fistula. And this little wick right here is identifying the little fistula that's extending from the maxillary sinus into the oral cavity. And again, learn to look at these, because I have to admit, for a large portion of my career, I didn't really look at it. Anytime that you have patients that have unexplained infections involving the maxillofacial region, make sure you look at the bone algorithms, because what we see here is that when you do have infections involving the oral cavity and they erode the buccal cortex, they can result in a submental or submandibular space abscess, or more commonly, they will give you this unexpected or unexplained facial swelling. So it's always important to look very, very closely adjacent to the sinus to see whether or not this is arising from that junction of the palate and the inferior portion of the sinus. This is a patient that has bilateral maxillary exostosis. This was a patient that had bilateral osteomas, that this patient ended up having Gardner syndrome. And this was a case I saw probably about 6 months ago. This was a sinus CT. Now, when you're looking at this, you're probably going to call it normal, but learn to look at the bony structures. Here's the anterior portion of the ramus of the mandible. Here are my stripe signs. I love tigers. So here's the masseter muscle. Here's the fat right here. There's the buccinator muscle. So this is normal on the right, but look at the left. Now you know what normal is. Notice how there's erosion right here involving the anterior portion of the mandible. And notice how I'm losing my stripe sign here. I'm losing the beautiful stripes. And this patient actually had a left retromolar trigone carcinoma. And the reason they had facial pain is because it was eroding the anterior portion of the mandible. And this was another example. This patient had mucosal thickening involving the left maxillary sinus. Well, is this due to polyps by itself? Well, when you look at the palate, notice that there is a well-defined erosive process involving the hard palate that eroded the maxillary sinus, and this was due to adenoid cystic carcinoma. So again, learn to look at those bony structures, look at those adjacent structures. Well, when you're also looking at the maxillary sinuses, we should also look at the brain. This was a patient that had ventriculomegaly. This was a patient, if it's kind of hard to see, but notice how the cortex doesn't go all the way to the inner cortex of the brain and there's low attenuation. This patient, when we sent him for a brain MR, because we picked this up, this patient actually had chronic subdural hematomas. This was a patient that had an air fluid level, was involved by trauma. If you look real closely, we can see this little bony defect right here. And this patient actually had a subdural hematoma. And the trigger point was here, again, that air fluid level. And there's that little oblique lucency. And that tells us that there's a fracture involving the wall of the posterior sinus. One thing that you should always do is take a look at the sella. Again, I showed that case earlier about intracranial hypertension. This is a patient that has an enlarged sella. We can see there's no pituitary adenoma in this case, but if you see a very, very enlarged sella like this in a patient with headaches, we always have to consider intracranial hypertension. This was a patient that had a lipoma involving the corpus callosum. And this was a case I saw probably about 2 months ago. You can see I've had some difficult cases recently, but this is a patient we were looking at the sinus CT, and lo and behold, when you look at the anterior skull base, this patient had a small little meningioma. And so again, you can see these. Back when I was a fellow, there was one of our techs that went for a sinus CT in the middle of the night. They also had a meningioma that was causing their headaches, and the headaches is why they had the sinus CT. So again, make sure you look at those intracranial contents. Well, the orbits can be a bit of a challenge too. This was a patient that had bilateral thyroid ophthalmopathy. So when you are looking at the sinuses, make sure you look at the orbits, and here we can see diffuse enlargement of all the extraocular muscles. Here's a patient, you look at this and you'll say, aha, I did a good job here. I picked up this mucosal thickening involving the ethmoid sinuses, but lo and behold, look at the erosion right here involving the superior portion of the lamina papricia. And now there's extension medially to involve the superior portion of the orbit with a little bit of scalloping. And this was all a mucocele. So when you're looking at the sinuses, make sure you look at the orbits. You can pick up that mucocele. And this was a patient that had mucosal thickening involved in the ethmoid air cells. Notice how that bone is intact. But remember, what was that one of the first slides I showed? Remember those draining emissary veins. And this patient actually ended up having a subperiosteal abscess. So despite the fact that the lamina propria is intact, you can still develop these little subperiosteal abscesses. This was a case I saw when I was at UNC about 35 years ago now. Again, it was a Friday afternoon. I'm looking at this sinus CT, and I'm looking at all this mucosal thickening. There's a little bit of mucosal thickening here. There's, I should say, air. There's air here, but I'm like, hold on for a second. That air is not in the maxillary sinus. That looks like it's in the orbit. And when we looked at the coronal images, lo and behold, this patient has mucosal thickening involved in the sinus. The patient actually had a blowout fracture that was never repaired, and all of this infection extended into the orbit and ended up having an orbital abscess. So when you do see air in the sinuses, the bottom line is, if it's not in the sinus, make sure you follow it up and start worrying about potential ominous complications from these sinuses. Now, this was a patient that ended up having a cone beam CT. And the point that I want to make is that if you are doing limited or cone beam CTs, make sure it's done for the proper clinical indication. So if you have regular sinus disease and you want to do it, that's fine. But don't do cone beam CTs for patients that have a known carcinoma. Why? This patient had adenoid cystic carcinoma involved in the sinus. So the initial person that read this just called this mucosal thickening. But look above the orbit, look above right here in the floor of the orbit. There's too much soft tissue thickening. And when we look at the floor of the orbit, this is V2 on the left. See how it's enlarged on the left compared to the right? So unfortunately, this patient actually had recurrent tumor involving his orbit, the adenoid cystic carcinoma, with perineural spread. And that tingling of the nerve, that facial tingling, is why they underwent the sinus CT. So if you are just going to do cone beam CTs, make sure you do it for the right indication. And certainly all these patients, at least in my opinion, deserve to have soft tissue algorithms performed. So one of the things that we can also look for is this. You're looking at your sinus CT, but now you have mucosal thickening involved in the mastoid air cells. Remember, the mastoid air cells are air containing, and we're responsible for those on the film. So anytime you see this, remember the eustachian tube connects to the mastoid air cells. If you say unilateral mucosal thickening to the surgeons, they always have to look specifically in the area of the fossa of Rosenmuller. And this patient ended up having nasopharyngeal carcinoma that obstructed the eustachian tube. This was the case I saw about a year ago. I'm looking at this mucosal thickening involved in the maxillary sinus, and I'm looking more back, and I'm like, there's mucosal thickening, and all of a sudden, I don't see the petrous apex. Turns out this patient did have a fever, but what they weren't aware of was that this patient had a huge skull base osteomyelitis. So again, we're responsible for everything on this film. And if I didn't pick this up, I could have been in trouble. But luckily, I was able to pick that up. Sometimes patients will undergo sinus CTs. They have facial pain. Remember, temporomandibular joint arthropathies can give you this facial pain, so you have to mention that. Here's a patient that had mucosal thickening involving the sphenoid sinus, but if you look real closely, you should normally see a clivus right here. That clivus is not there. And look at this increased soft tissue thickening, and this patient ended up having nasopharyngeal carcinoma that had eroded the clivus. And again, this was a case I literally saw 3 weeks ago. This was a patient that had a lot of polypoid mucosal thickening involving the maxillary sinus and the ethmoid sinus. Well, you're about to dictate it. Remember to look at the axial images, but lo and behold, this patient had a lot of erosion involving the skull base. This was not due to this polypoid thickening. Rather, sometimes patients can have two diseases. And in this case, this patient actually had a brewing nasopharyngeal carcinoma that was behind all of this disease involving the maxillary sinuses. And remember, we're responsible for everything else. Oftentimes, we'll see the soft tissue thickening in the visceral space. I always say get follow-up imaging, especially if I see this in older patients, because normally the adenoidal tissue is involute, and especially if I see something that contains or is a stalk. This needs to be evaluated. This turned out to be squamous cell carcinoma. Remember to look at the screening studies. This patient on a screening sinus CT ended up having this soft tissue mass right here involving the tongue base, and this was a tongue-based carcinoma. There's no way they're going to be able to see this on routine exam, but we could pick this up by looking at the tomogram or the scout images. So always force yourself to look for that. Here's a patient that has a regular sinus CT, has an expansile mass involving the masticator space. This patient had a mass involving the parapharyngeal space. This patient, when you look at this, there's the mass right here involving the right. And when we look at the MR, this patient had a buccal space mass. And I see this not infrequently. You're looking at the sinuses, and then lo and behold, we see all these little punctate calcifications. And this patient ended up having chronic sialadenitis from Sjogren's disease. So when I put this talk together a while ago, I remember I talked to a radiologist whose wife is actually a malpractice lawyer. So she actually sues radiologists. So for me, it was an interesting resource. So I remember I asked them and I said, look, if I'm looking at a sinus CT and I'm really looking at the sinuses and I see something else that's not related to what I'm looking for, am I responsible for that? And the exact words from her were, if it's on the film and it's significant, I'm coming after you. And that really kind of put the fear of God in me. So as a result, I just want to emphasize that just realize we are aware for everything on the film. And even for the surgeons that are looking at this, if you pick up something that they cannot see, again, they're really going to like you, and that's going to really strengthen that relationship. So what I wanted to do in this final slide is say, yes, you know what? Sinuses are low-hanging fruit, and they're relatively easy to read. The majority of them are going to be, very straightforward. They are low-hanging fruit. But what I also want to mention, too, is that there are a lot of alligators in sinuses. And I do want to emphasize that you have a structured approach to look for the sinuses, because what you do want to do is stay out of this lake where they have the alligators. So thank you very much for the opportunity to be here. I am on YouTube, X, and LinkedIn. We have about 25 of our talks right now. And hopefully, if you can give me a copy of this, I'll put it up there as well, too. Like I said, I'm not smart enough to develop an iPhone, but this is a free channel, and it's just my small contribution to radiology. So again, thank you for the honor of being here, and I'm happy to answer any questions.
Thank you, sir. Hello.
Yes, I'm here.
Thank you, sir, for a wonderful session. I would like to mention it was a wonderful topic, wonderful discussion, wonderful information regarding everything. You have covered all surgeons' graveyard 4 points. Basically, we look into for the cibriform plate, the lamina trapecia orbit, and definitely sphenoid sinus to look for the optic nerve and the carotid artery. I would like to say to the Apollo persons, just arrange a carotid Doppler for us, because it is not a mucosal thickening, it could be carotid also. This has been a great information regarding the sinuses, sir. The only thing, I have one question to you. Do you consider combo scans to look for the detailed pathology of invasive fungal sinusitis, or anyone else, any pathologies you consider for the combo scans like MRI in combination with the CT?
Right. That's a great question. What I would say is this, is that normally we start off with the CTs in most of these cases, and then we'll look at the bones and we'll look at all of the surrounding soft tissues. And if all of that is negative, in general, we stop. But on the other hand, because the earliest findings can completely mimic mucosal thickening or just standard mucosal thickening, and also, as you know, in another talk, you can have necrosis involving the soft tissues of the nasal cavity that we may not see on CT. So if there is a high clinical suspicion, then those patients can go for MR. And again, in the United States, we are very sensitive to healthcare costs. We are sensitive to how much people have to pay for these. So in general, we tend not to order them directly in combination. But if one will do the first scan, and if there's any further clinical suspicion, then we may go to the second scan if you feel that as a surgeon it's indicated.
Okay. Sir, second last question to you. What you will consider as a gold standard for the CSF leak, whether it is CT cisterno or the high gadolinium enhanced MRI?
And you're referring to, I'm sorry, the CSF leaks?
Yeah.
Yeah, that is a great question that's been debated for about 30 years or so. Again, unfortunately, or fortunately, I'm old enough to remember the days before MR and CTs when we did it. So I can tell you at least my impression how it's evolved over time, because again, if you ask 10 radiologists, you may get 10 different opinions. But from my standpoint, what I think that we should do in patients that have CSF leaks as documented with beta-2 transferrin is that if you feel that there is a leak, then my feeling is that we should do a thin section CT with bone algorithms and then follow that up with intrathecal contrast. So we will do a CT scan. And in the old days, when I did it, I still think it's the best way. When you give the intrathecal contrast, you tend to turn the table. We would actually get patients in the doggy position. So we would actually, it's like now we call it a downward dog. It's more acceptable. So if you do yoga, you're familiar with the downward dog position. So we would inject the contrast ethically, put them in downward dog, and then that contrast would flow into the brain. And then we would do the post contrast CT. And then we would end up looking for the see whether or not there's any contrast extending into the sinuses. The reason why we do the pre-contrast is that sometimes the mucosal thickening in the sinuses can be high attenuation from desiccated secretions or fungal colonization. And if you just did the post, sometimes you can't determine, or can be confusing, whether the high attenuation is due to contrast or whether it's due to the secretions. There have been some studies done with MR. I think if you have experience with MR and you have the right inverted, you have the ability to invert the images and then do the proper acquisitions, I think it's great. But to me, what's most reliable is the CT cisternogram.
Okay, perfect, sir. Thank you.
Dr. Suresh, there are a few questions in the chat box. If you don't mind, I will just summarize a few of the questions.
Yeah, I've got a few minutes, so yeah, it's no problem.
So there are the questions that incidental findings on CT, how much it leads to overtreatment, and how should clinicians handle them?
Yeah, I think it's a great question. I think over-treatment's an interesting concept. I think part of our job is to point these out. When I do talk to some of my other clinical colleagues, like I say, I see patients. I do it at 2 or 3 tumor boards a week, and I see patients on Wednesdays. On the one hand, you have the lawyers that are going to say, well, if there's something on the things and it's significant, they'll come after us. But on the other hand, when you are taking care of patients, you have a physical examination, you have the history, you have a variety of other laboratory values, and then you have the information that's provided on imaging. So as a practicing physician, you have to take all of that information and put everything into context. So if you do pick up some of these incidental findings, it's up to the referring physicians to determine the importance of that finding and whether or not it's worth following that up, because it may just not be, helpful at all. So I think the overtreatment can occur if, I think I would say one other thing too, the overtreatment can occur based on how dogmatic we are in our reports. So from my standpoint, if I see something like this, I will just mention it. But on the other hand, if you do say there is something that you've found, and then you say you should get X, Y, and Z, then you kind of pin your referring physician into mandating follow-up imaging. And at least in my experience, that kind of leads to more over-treatment than sometimes just mentioning the findings. So I think we also have to be cautious, not only mentioning this, but also saying how much emphasis we should place on further evaluating it. So it's sorry for the long answer, but it's an important question and something that we face more and more as we perform more imaging.
But this answer was required because this is something that all of us as radiologists face quite often. I agree to that. And there are a few more questions. I will just summarize a few of these questions. The question that one of the candidates have asked, what are the key details that referring physician or the doctor should include to improve the radiological reporting accuracy?
Yeah, that's a great question. And thanks for asking that. Please give us as much history as you can. Please, please, please. I cannot emphasize that enough because, if you want accurate information, you have to tell us. I can't tell. Like I say, I don't know how many cases I read a week. I get them from all over. We have private imaging centers. I have a teleradiology network where I get images from all over the country. Then on the academic side, we have, at the various universities I'm affiliated with. I can't tell you how many times the right and the left is incorrect. I can't tell you how many times that I get things like mass when I'm looking at an XCT. And then I have to call up and I said, where is the mass? And I always emphasize to our techs, if the patient has a palpable mass, please put a skin marker on it. If you are ordering studies and patients have visual loss, please comment on the visual loss. Is it monocular? Is it bilateral? Is it homonymous hemianopsia like tunnel vision? I should say heteronomous hemianopsia like tunnel vision. Please give us as much information as you can. So, and if you can actually include your H&P, I like to read those myself. So the more information that you can give to us, the more accurate and precise and greater value add we will be able to include in that report.
Just last question, Dr. Suresh. Which are the most important anatomical variations which will help the surgical risk? Anatomical variations, the CT scan that we should pick up, and which are the most important for the surgical interventions?
That is such a great question. When I guess I always say this, but you're supposed to tell me I don't look this old, Vinita, but I still remember the days before functional endoscopic sinus surgery first came out. They would do something called a Caldwell look procedure. And there's still patients that are running around with Caldwell looks because you would basically do a sublabial incision. But then around the late 1990s, up at the University of Pennsylvania, they came up with functional endoscopic sinus surgery. And that really pushed forward our ability to look at sinus CTs. So once we started doing coronal sinus CTs, we started noticing all these variations. And so in the next thing you know, you have like 20 sinus variations that you could routinely see on the studies. So then the question came is, how many of these do you really include? So fortunately, if you go back and you look at the papers written in the late 2000s, and I think Peter Somm was one of the first people that did it, what he fortunately said was, you don't need to comment on every single anatomic variation. But what you should be able to do is comment on the ones that could potentially affect functional endoscopic sinus surgery. So for instance, if the patient has a large Haller cell and it's opacified, and on that side, there is opacification, because then the surgeon not only has to do the uncinectomy, but they're going to have to resect the Haller cell. Similarly, some patients are going to present with potentially facial pain, and they have a large septal deviation with a large right nasal spur. that can potentially cause facial pain. You know, the whole thing about looking at the apex of the maxillary sinus and determining whether it's odontogenic in origin, that's going to triage the patient. Sometimes you're going to have enlarged ethmoid buildup. So the bottom line is, for me, and I didn't have time to get into it, but if you look at the normal drainage of the sinus, which is the primary ostium, the uncinate process, the hiatus semilunaris, the middle meatus, all of those congenital variations that could potentially obstruct the flow of that sinus, if it's on the ipsilateral side of the thickening, then those are some things that we should always comment upon. And then the last thing is that if I do see a patient that comes in with demineralization of the cribriform plate in an adult, and they do have ipsilateral thickening involved in the superior portion of the nasal cavity, you know, I will comment on that because some of those patients could have occult CSF leaks. So again, it's a long answer to a short question, but I just wanted to try to give you some take-home points.
I was just going to ask, would it help if you write the findings and write it's an anatomical variant?
Yeah, I think that would be fine. Again, a lot of it gets into working with your rhinologist and then also your template. So for instance, when I showed the cheetah, I don't know if you remember that cheetah, which was a one-line thing, you know, that's kind of a screening saying there's disease or no disease. Is it surgical or non-surgical? If you're at working with people that do rhinology every single day, or if you're at a tertiary or quaternary care institution, you know, you can work with them to determine how detailed you want to be. From my standpoint, sometimes I don't know what's normal or abnormal. And the other thing that I will say too is that I talked to one of my rhinologists, and what they asked me to stop saying is, don't comment whether it's mild, moderate, or severe. Some places do this. Now, in an academic center, oftentimes you'll be asked to put mild, moderate, or severe. In the real world, you'll have surgeons that, especially in the United States, that feel that the patient needs to have functional endoscopic sinus surgery. But because the radiologist specifically said the ostium was open or there was mild thickening, the patient may get denied the surgery because the insurance companies will kick it back and they'll say, well, your radiologist doesn't think the patient deserves this. And again, this is what happens in the real world, if you will. So I think if you want to put the anatomic variations, I think that's great. I would work with your surgeons to figure out which specific anatomic variations they feel are important.
And I think so it also depends upon what kind of surgery the patient is going to have eventually and what will help it. Okay, I think so we should end the session.
Yeah. So I think I would, yeah. So firstly, I will like to thank Dr. Suresh Mukherji for the very, very informative talk. It has really enlightened us quite a lot on the CT sinuses. Then thank you, Dr. Saurabh Pachori, for being the chairperson for the session, and Dr. Nidhi Goyal for being the moderator for the session. And last but not the least, also all the audience for being there and your, active participation, asking questions. I hope your questions were all answered to your satisfaction. And I would also like to thank the Doc Plexus team and the technical team of Gapio. I think special mention of Mr. Jitendra Malik, who has been a pillar of support for all our webinars through the years. So I would thank you all of you again. And I think Shifadi is there. Shifa, Dr. Shifa is there.
Yes. Thank you so much, ma'am. And on behalf of entire Dr. Plexus team, we really thanks each and every faculty member present here for sharing our valuable insights on such a wonderful topic. Thank you, everyone. And special thanks to our audience for your valuable contributions throughout the session and asking questions during the session. Thank you. Thank you.
Thank you. So we'll end the session now. Thank you.
Thank you.
Thank you.